Ready?
Equipment is aseptic and ready for use. You sure we're ready?
Having doubts?
It's to be expected.
Not for me.
How can you be so certain? Perhaps a few more trials with the female subjects. I can help pay for their time.
I must need to. They are more proof of God than anything else I've ever seen on this earth, but their usefulness to us, at least medically, has passed. What you choose to do with them on your own time is entirely up to you. Dr. Chickering is now inserting the deflated bladder, which is sheathed to keep the shape small while entering the vaginal canal. We are now entering the uterus. With this new procedure, there is no danger of exsanguination, as our bladder has slowed the bleeding to a trickle. Retractors. The baby is alive. The patient will live to mother it. Gentlemen, I give you the Christensen, Thackeray, Chickering placental repair.
Hello, my audience. Thank you very much for your attention to this clip, which was taken from one of my favorite drama series. It's a period drama on medicine, um, portraying the Knickerbocker Hospital, which is actually a real-time hospital that was built in Harlem back in 19th century. And then this guy, Clive Owen, um, portrays Dr. Thackeray, a great genosurgeon. Anyway, today's talk is about modern operating room. Well, usually when the organizers put this kind of talk in the meeting, that means the audience is kind of sleepy. They want to have some imagination of their free will. So here I am. My name is Rehan Bin Asif. I am a consultant gynecologic oncology at famous Shaukat Khanum Memorial Cancer Hospital and Research Center. I was trained and later practiced in the US until December 2019 when I moved back here. I am very grateful to the organizers, especially my brother-like senior, Dr. Talat Wasim. You guys know that being a surgeon, we all know or can be an intimidating place for non-surgical colleagues. Operation theater, what we now call as operating room, is actually a reminiscent of real theater, where we watch the drama and at times invoke the feeling of wonder and awe. Obviously, the only difference is we always give a live performance, and it's always the best. We can't afford nothing less, right? So our talk is from here till here, like more than 300, 400 years ago, which you can see, to here, the modernistic operating room. In the ancient times, Operations were performed on as is and where is basis. The surgeons will walk to the patients with their toolboxes and perform surgical procedures, in their houses, the camps, streets, and battlefields. Remember barracks. The procedures were limited to the emergency or life threatening situations only. We were incising the abscesses, probing the fistulas and sinuses, dilating strictures, excising superficial lumps and doing amputations. You can imagine the cruel times, an attendant having a sandwich in his hand and the race against time. Blood was collected in the sawdust boxes and flaps were left unsutured. If you remember, actually, Liston and Ferguson, who were back in the days, late 18th and early 19th century, they were able to amputate a thigh, including wound closure and dressing, in less than 3.5 minutes. 3.5 minutes? Can you imagine? In those times, the best surgeon is the one who would remove the leg in 30 seconds. How many of you can do it? I'm sure none. I'm sure none. You know, like any sportsman, any performer, a surgeon needs a field where he can play and show his moves. We, the surgeons, have big machismo. We have a huge ego. Nobody can deny it. But, you know, our forefather, Surgeon Ferguson, once said, a surgeon is the one who has the eye of an eagle, the heart of a lion, the hands of a lady, and the flair of an accomplished actor. In order to show all these talents, we need a theater. Hence, obviously, the term came Operation Theater. In ancient times, operation theaters were the seats of excitement and tragedy. You know, you expect horror and terror there. It's all filled with cries of the patient and gasps of witnesses. You'll find struggling patients and willing volunteers holding them down. The professors or the surgeons were known for their courage and speed, nothing more. It was not until the 16th century when we started thinking about the actual theaters. You know, the idea came from the famous Anatomy Amphitheater back in Padua, Italy. And then we started operating in these theaters on live patients and demonstrated to an enthusiastic surrounding audience. Yes, the same audience that had no regard to contamination, sepsis, or eventual pain. And obviously, finally, you'll get a bow from the audience. Success is the only option. The only option. Now we are in this era of hybrid operating rooms. A hybrid operating room, in my lingo, is a hodgepodge of different specialties. It's a collaboration between some specialties that are working together, like surgeons, the radiologists, the cardiothoracic surgeons, the trauma surgeons. They come into play in a big operating room where they have all the facilities from radiology to intervention to C-arm and obviously the surgical stuff. Here's the clip. Look at this clip. This is not from a sci-fi movie. This is not Hollywood. This is an actual hybrid operating room that started working in 2016 in Boston. This is from Brigham and Women's Hospital. You can see they have all the fancy gadgets in a big operating space. That's the present. This is not the future. This is just the present. You can see all the essential gadgets there, working at their own pace. When it comes to the operating rooms, there are four major questions, very simple, straightforward questions. What is the hospital's goal? What is that hospital is trying to cater? Who is driving the function of that space? Like if you are considering an OR and trauma is the biggest specialty that is going to use it, obviously that's the one driving the function, right? Or radiology for that matter. What kind of procedures are you planning to do? Are you planning to do just a straightforward trauma procedure, or are you doing any complex trauma procedures, including CT surgery and cardiothoracic, angiography and whatnot, right? And what is the budget? The bottom line is always the money, the greens, the dollars, right? So, what is the budget? You have a pocket full of cash, you'll get what you want. Imagine, just imagine, a few years ago, Alberta, Canada, um, medical center in Foothills, Foothill Medical Center in Calgary, actually started an OR. It is an interventional trauma operating room. They spent almost $6 million. How much? $6 million to renovate a space of about 1,600 square feet to operate on complex patients. So this is the level 3 trauma center, right? And they're using that facility very well. This is just the present. You're not talking about future right now. But future, what's in the store for the future, right? We have come a long way during this century with the emergence of highly specialized surgery like transplants, right? And there has been a transient rebirth of the operating amphitheater to allow the drama to be witnessed by the observers, right? We are likely to have operating theaters in the next century very much like the amphitheaters of the past, but obviously loaded with modern technology. The laser, the ultrasonic knives might replace traditional scalpels, although it is hard to believe that the standard surgical knife will become obsolete, but you know, it can be expected. Audiovisual technology will have a very prominent role. A whole wall will act as a widescreen TV in place of just a small television monitor. Um, closed circuit closed circuit televisions will help to teach and train. Teleconsultations during operations between the operating surgeon and any advising authority, whether that person is around the hospital or sitting across the waters, you know, it should be possible with satellites and appropriate equipment in operating rooms. And someday, believe me, someday the robots will take over. And I'm not just kidding, you know, you'll see robots doing standard procedures like repetitive jobs like shaving, cleaning, toweling, positioning, even opening and closing, probably zipping the cavities. But the question is, where will this end? I don't know. I don't know. Some people think we have reached these final limits, but I don't think there are any limits to this. It's limitless. It's limitless. We can only imagine what the operating amphitheaters of the next century will be like, perhaps with miniaturization of access and equipment. The surgeon of the next century may just walk, drive, and even fly with his paraphernalia and operate wherever the patient is. Under those safety and bloodless surgeries and antibiotic umbrellas, it's possible. Popularization of day surgery and outpatient procedures, advances in endosurgery and gene therapy may make standard operating theaters redundant and obsolete. That's very much possible. You know, it all depends on your imagination. future holds artificial intelligence and augmented reality. We all know these two things will change and obviously rule the future. Everybody knows that. You have read the studies on the current advances in radiology. That's happening already, right? It's not far. My colleagues, it's not far. It's not far when you see robotic, enclosures where these robots are operating on the humans with no mistakes, no complications. It's not far. Not more than 50, 60 years. You'll be able to see it if you live by then. Thank you for your attention and your patience.